Hello, everyone. I'd like to welcome you to today's webinar, Dislocation and Subluxation Management in EDS and HSD with Jason Parry. My name is Sarah Jo Ritchie. I am the volunteer coordinator at the Ehlers-Danlos Society, and I'm your moderator today. This webinar is part of our ongoing series, Living with EDS and HSD. So this is how today's webinar is going to work. Webinar attendees will be muted at all times during the webinar. However, you are able to type any questions you may have throughout the presentation into the question box at any time. Jason will not be able to see or respond to any questions until the Q&A portion at the end of their presentation. Please do not send your questions more than once. It will not increase your chances of having your question answered. It will only make it harder to sift through the questions and to make sure we're able to get to as many of them as possible. Jason is a clinical specialist physiotherapist in hypermobility and extended scope practitioner. Currently, he splits his week working within the specialist hypermobility unit at the Wellington Hospital, as well as the University College Hospital London, as an extended scope physiotherapist in hypermobility, running assessment and diagnostic clinics. He is a member of the EDS UK Medical Advisory Panel, authoring several medical information leaflets, writing information articles for their member magazine, and collaborating with other panel members in order to help advance the treatment and management of the condition. He also lectures nationally and internationally on the subject of hypermobility. He previously worked at the Royal National Orthopaedic Hospital, Stanmore, London, for 11 years, spending the last 6 as one of the lead physiotherapists on the residential hypermobility rehabilitation program. He also retains a special interest in the treatment of complex regional pain syndrome. Earlier in his physiotherapy career, he spent 5 years working for Premiership football club West Ham United FC, where he was responsible for running assessment and treatment clinics for the elite academy players. He is also qualified as a Pilates instructor and acupuncturist. Thank you so much for being here today, Jason.
You're welcome. Thank you. Lovely to be here. I'm obviously going to talk about dislocation or subluxation management, or as I like to call it, I'm just popping out for a while. So what we're going to cover today is we're going to look at the difference between a dislocation and a subluxation. We'll look at some of the reasons as to why these incidents happen. And then we'll talk about some of the common responses when such episodes occur. So the way that people tend to usually react to such incidents. Then we'll talk through a suggested management protocol for trying to manage these incidents. So how we can deal with the situation better. Then we'll talk about what to do if the joint doesn't go back into place and when it's appropriate to seek further help. And then we'll touch on prevention of future occurrences, because obviously prevention is much better than management. You know, stopping these incidents happening in the first place is obviously the best of all. Okay, so let's get started. So we'll start off by actually just looking at the difference between a dislocation and a subluxation. So according to the Oxford English Dictionary, a dislocation is basically a displacement of a bone from its natural position in the joint. Obviously a joint is where two bones meet each other, and a dislocation occurs when those two bones fully separate from each other. So that's a full dislocation. So we have a couple of quick examples here. So this is the dislocation of the shoulder. So the humeral head here has slipped out of the back of the glenoid of the shoulder. So that's a full posterior dislocation of the shoulder. And then the elbow here. I think you'll agree that this is not supposed to be sitting where it is. It doesn't look right. And that is obviously a full dislocation of an elbow. So then a subluxation. So to subluxate is basically to partially dislocate. So this is a partial dislocation of the joint. The joint hasn't fully come out of place. And subluxation episodes can be relatively transient. So they can be very quick. They can just come and go, so in and out, in and out. And sometimes some people actually really struggle to know or appreciate when they've had a subluxation. It can be quite difficult. So sometimes joints feel like they're very unstable and feel like they're moving around or slip around, and you feel like clonks and clunks. And sometimes that can be a subluxation of a joint. So again, some examples here of a subluxation. So we have a knee. So the kneecap has slipped, just displaced laterally. So it's just gone over to the side. So outline there in black is, in the black lines, is where it should be sitting. And you can see it's just partially moved across. So that's a subluxation of a patella. And then we have an inferior subluxation of a shoulder. So unlike the previous shoulder example that we looked at, this shoulder has just partially dropped out of its socket. So it's not fully sitting out, it's just partially out. Okay, so dislocations or subluxations, these can happen in any joint, but some are more common than others. And amongst these are shoulders, knees, thumbs, and ankles. So these tend to be real common joints for this type of thing to happen. And there can be some reasons for that. It can be to do with the shape of the joint. So, for example, the shoulder has a much shallower socket. It's a ball and socket joint with a shallow socket. So that makes it a bit easier for that ball to slip out, probably more easy than something like a hip, which is a much more congruent joint where that ball really snap locks into a socket. And knees, thumbs, and ankles are also very frequently found. So again, we've got a couple of examples here. So a shoulder that's dislocated, and you can see that there's what's called a sulcus there. So there's like a big gap because that ball has slipped out of that socket. And that doesn't look right there either, does it, on that knee? So I think everybody would agree that that kneecap most certainly shouldn't be sitting in that position. So why does this happen? Why did we get these events? Well, the main reason, and there are a few reasons, but the main reason really is based around connective tissue. So as I'm sure you're aware, connective tissue is the tissue inside of us that supports, binds, connects, protects, or separates other tissues or organs. So it's the stuff inside of us that basically creates a framework for our body. And we're talking about things like ligaments, tendons, cartilage, bone, skin, blood vessels, intestines. These are all made of connective tissue. Now, with regards to dislocations and subluxations, we're mostly thinking about ligaments and tendons, that connective tissue. Now, ligaments and tendons basically act like little guy ropes. So the role of ligaments is basically to connect one bone to another bone. So your body is full of ligaments, and whenever you have a joint where two bones meet, you've got ligaments. So as we can see on the right here, we have a knee. So we've got a side view of a knee, and we've got the femur up here, the thigh bone, and we have the fibula here, and we have a tibia, and we have ligaments here going between the bones. The role of ligaments, as mentioned, is basically to connect those two bones. And as that joint starts to stretch, as that joint starts to move, as you extend that joint, those ligaments should tighten up and get much tighter and prevent that joint from coming too far apart. And tendons also have a very similar role, except they connect the end of a muscle to a bone. We also have, within a joint, we have like a sleeve of tissue that sits around a joint called a joint capsule. And this is basically, I mean, you could almost think of it like a bag that basically sits around a joint. And a joint capsule, again, is just a sleeve of tissue surrounding this joint and encapsulating the joint, so helping that joint to stay in place. So with all of that in mind, we are interested in collagen. So connective tissue is basically made up of proteins. So there's various proteins that make up connective tissue, the building blocks for connective tissue. And the main structural protein that builds connective tissue is collagen. And collagen is made within us. It's made within our genes. It's part of our DNA. And in people with hypermobility, it's an alteration in the type of collagen that people with hypermobility make that causes their connective tissue to be more lax or more stretchy. So this means that the collagen that makes up things like ligaments and tendons has a stretchier capacity for it. It has more play, more give. So it's not that people with hypermobility make less collagen or more collagen than anybody else. It's just a different type of collagen, a stretchier type of collagen. So this has implications if the type of collagen that you make is stretchier. This means that potentially there is more laxity at your joints, and the joints are potentially less stable, and this leads to subluxations and dislocations. So if we think back to ligaments, for example, so you have a joint and you have a ligament connecting those two bones together at a joint. As you start to stretch that joint, or as that joint starts to move, the ligament should tighten up and prevent that joint from dislocating. But if your ligaments are basically of a stretchier type, then that increases the capacity for that joint to go further, which is one of the reasons why hypermobile people are able to achieve hyperextensible ranges in their joints. Now, in some cases, if that laxity is significant enough, then that ligament or the tendons won't necessarily hold the joint in place, and then that joint can slip out, and it can either fully dislocate in some instances or just partially slip out, which again, as you know now, is subluxating. And if you haven't got good control around a joint as well, and if you have laxity of that sleeve of tissue, that capsule that sits around a joint, then that's also not going to help the situation, because if you have laxity of that sleeve of tissue, that capsule, then that will also allow for that joint to slip out of place and dislocate. So this is one of the main reasons why this can happen in the first place, because of this laxity due to the altered collagen type. But there are other reasons why people can suffer from joint dislocations and subluxations as well. And probably one of the key reasons is due to altered muscle tone. So our bodies are riddled with muscles, and all around all of our joints and everywhere we've got loads of muscles. And when you have inherent joint laxity in your body, and when you have instability, then your body is trying to always help itself in the best way that it thinks it can. And what often happens is that all different muscles try and switch on to try and find some element of stability. So what you get is a whole load of different muscles all switching on and staying switched on for long periods of time to try to compensate for the extra flexibility that you have within your body. Now, this can be very tiring for muscles, and particularly tiring for those muscles that for whom that isn't their job. And this is what leads to a situation called muscle patterning. So sometimes we find that certain muscles start to switch on inappropriately, and those muscles can exert pulling forces on joints. So if we take something like a shoulder as an example, what we often see is that people can suffer from dislocation or subluxation episodes of shoulder due to muscle patterning of things like pectoralis major muscle, which attaches, has a tendon that attaches onto the shoulder, and then that can inappropriately switch on, and it's quite a strong, powerful muscle, and then that can exert a pulling force, so that tendon will pull that joint out of place. And we also see another example in the shoulder is latissimus dorsi, so a big muscle, kind of wing muscle that sits down here, can exert an inferior pulling force. So again, if that muscle is switched on inappropriately and working much too hard, much harder than it should do, then that can pull that joint out of place. And this is what often happens in many people. So we find that there's inappropriate muscle patterning, this pulling force that pulls joints out of place. Again, a knee can be another example. So the kneecap can often be pulled laterally as a result of powerful muscle forces pulling on that kneecap. And this, together with the inherent laxity due to the collagen, allows for those joints to dislocate or subluxate. And then what happens is, When these muscles are overactive and overworking and working more than they should do, they start to spasm. And when muscles spasm, that also exerts a pulling force, and then that becomes very difficult to try to break that. Muscles get achy and fatigued, and then we have a stress situation as well. So altered muscle tone is a very big reason why some of these incidents happen. But again, there are other examples or other reasons why we get these incidents. So impaired proprioception is another reason. So proprioception is basically another word for joint position sense. So this is the awareness of where our joints are in space. So we have little joint receptors that are in our joints, and they pick up on pressure and stretch changes, and they feed back to our brain about the position, about those changes, and then our brain makes very quick calculations and works out where those joints are. Now, we know that in people with hypermobility, the proprioceptive system is not as well tuned as it could be. And people struggle to have a good awareness of where their joints are. And this is one of the reasons why hypermobile people can often be clumsy. So they can misjudge things. They can walk into door frames, bang into tables, knock things over when they try to reach for them. So their joint position sense is not especially well tuned. Now, if your joint position sense isn't very well tuned and you don't have a great awareness of where your joints are, then sometimes that means that people can put their joints in very risky positions, so positions that will increase the chances of a dislocation or a subluxation. And often that will happen subconsciously. So somebody doesn't realize, for example, that they're standing in a particular way, and their knee is in hyperextension, or they've got it at a funny angle, which makes it much easier for that joint to then suddenly slip out of place. So impaired proprioception can be another reason why this happens. Obviously, a traumatic incident can be another reason. This is the most common reason for non-hypermobile people to dislocate. Obviously, they'll be involved in some kind of trauma, and the joint will get knocked out of place, and out it comes. Same things happen to people with hypermobility as well. But if you have that inherent laxity and that extra stretchability within your joints, coupled with impaired proprioception, then it often can take far less of a traumatic incident for a joint to slip out of place. So sometimes it can be a very, very innocuous little knock or a bang, and suddenly that joint will just slip out of place. And then repeated overstretching. So people greatly underestimate this as well. So these are the party tricks that people do. They show their friends. I'm sure loads of you guys have the capacity to do these various party tricks, to be able to sit in the W position or bend your joints to various different places, to extreme positions. Well, that's all well and good. Well, actually, it isn't all well and good. It's actually all well and bad, not well and good. So if you do too many of these party tricks, if you repeatedly put your joints into these hyperextensible positions, then you can increase the opportunity for those joints to become even more lax, and for those incidents to occur. So we've got an example here of Captain Frodo, who basically used to contort his body through a tennis racket. Now, if he continued to do this, then he is obviously stressing his joints to such positions that he can potentially increase the opportunity of dislocations and subluxations, because he's repetitively stressing and stretching already lax tissues. And another example here, we have the Snake Man, who used to be around in 1915 and used to hang himself off of fold himself up like a kind of a pretzel over a wooden bar. So if you do any party tricks, don't. So moving on to the dislocation or the subluxation itself. So it comes out, the joint slips out, and in some people this can be an event that happens incredibly infrequently. It may happen just once in a blue moon, and you know, that's them. In other people, this can be a regular occurrence. So in some people, these incidents can happen once a week, sometimes once a day, once an hour, or once every 5 minutes. And I've known all extremes. I've known people for whom this has happened just once, and I know people who've sat there in a clinic with me and dislocated, you know, up to 50 times in 5 minutes. Now, in some people, that joint will slip out of place and then it will slip back into place on its own. And if that happens, great. If it just goes out, in, what a relief. But even if that happens, it's still not a great thing to happen, and it can still be quite distressing, even if it's only for a couple of seconds. And we still need to see if we can reduce the frequency of that happening in the future, because we don't want it to happen at all, even if it is just momentarily. So what happens then for those people for whom the joint slips out and then it doesn't go back in again? Well, the understandable reaction is to panic. This is what usually happens. People will dislocate or subluxate, and it's a stressful experience, perfectly reasonably stressful. And in many situations, if that joint is sitting out of place, people will panic to the point that they'll end up calling an ambulance to take them off to the emergency room. And this is not a good plan, unfortunately. And I'll explain why in just a second. Because first of all, the understandable panic reaction causes more stress in the first place. So when you have more stress, it makes your body more tense. And when your body becomes more tense, your muscles get more tense, and then that creates more muscle spasms. And more muscle spasms equals more pulling the joint out of place. Because remember, as I was saying, when these muscles are spasming, they exert pulling forces. And then if they're pulling on a joint that's already slipped out of place, if that muscle is in spasm, it's going to make it much harder for that joint to go back into place. This also leads to more pain. More pain leads to more stress, which perpetuates the cycle. And so there's less chance of resolving the dislocation. Now, again, it's perfectly reasonable and perfectly understandable that people would panic when this happens. Not everybody does. Some people are very calm in the situation. But if you're a panicker and this happens to you, then what we need to do is start to try to see if we can break this panic cycle. So we need to not panic, breathe normally, and stay calm. So what do you do? So this is my suggested management protocol as to how to manage these incidents when they occur. So your joint slipped out of place, whether it be a dislocation or a subluxation. The first thing to do is try to stay calm, as difficult as it may be, and breathe. So try to breathe normally. So use some slow, deep, relaxed breaths, just nice and gently, and just try and use perhaps some relaxation techniques. So that may be just deep breathing, and there's relaxation apps and deep breathing apps that you can use, or you can try using some mindfulness or meditation, anything that's basically going to help you chill out. Chilling out is the big thing here, okay? We need to try to just breathe and try to stay calm in the situation. Easier said than done, I know, when a joint is out, but it's absolutely key to being able to manage this as quickly and as effectively as possible. So after that, use painkillers. This is a very painful situation, or it can be an extremely painful situation. So I would always advocate appropriate use of analgesia. Don't be a martyr, you know, don't sit there sucking it up saying, oh, I'll grit my teeth and get through it. If you have analgesia, if you have painkillers, use them, take them, but use them appropriately. Okay, so only take the dosage indicated by your prescriber. Never take more than the suggested dose. In a panic situation and a very painful situation like this, it can be very easy to start stuffing loads of painkillers down, but nobody wants that situation. So just take what you can take, but take it, okay? Use painkillers. We need to try to get on top of the pain if we can. Then support the joint. So supporting the joint, using a pillow or a sling or anything you can find to actually help offer a little bit of support and to find a comfortable resting position. So the premise of this is basically allowing those spasmed muscles, those muscles that are pulling and reacting, to actually be supported and to be able to calm down. And again, this is absolutely paramount in being able to manage the situation. So as illustrated in the pictures there, if you can find a position where you can lay down, or if you have a sling or use cushions, pillows, whatever it is that you can find, just to take the load off, to take the pressure off and support the muscles, then that can make a massive difference to being able to allow those muscles to just calm down and relax, because that's the big key to it. Then trying heat. So heat is often a very helpful thing to use for very overactive, very tight spasming muscles. So you can use heat in whichever way you find effective, via hot water bottles, those wheat bags that you can put in microwaves, a warm bath, heat patches, however you find. Heat often is useful in being able to help these muscles relax. And then distraction. This is easier said than done, again, but if you've got a dislocated joint or a subluxated joint, then that is understandably going to be the main key focus of your attention at that point in time. And if the situation is very stressful and the muscles are really overactive and firing away, then you need to try to see if you can just focus your attention a little bit away from that, just for a short period of time. Again, because the more you're panicking about that situation, the more you're feeding into it. So just trying to use some form of distraction technique, if at all possible, whether it be watching a movie, listening to music, talking to friends or family, relaxation. This can be helpful. This distraction is a short-term pain relieving strategy, because again, if the pain is the sole focus of your attention, then all you can think about is that pain. So if you can somehow try to distract yourself, again, this can start to try to help the muscles relax. And then finally, massage. So sometimes just a little bit of gentle massage. And I say gentle because it needs to be just nice and easy, nice and gentle. Can sometimes help to relax the muscles enough to be able to relocate that joint and just help it slip and slide back into place again. So just very gently, perhaps using a little bit of massage cream or oil, just gently going over those overactive muscles just to help it. So the 6 key principles of managing these incidents when they first occur. First of all, don't panic. Again, try to stay calm. It's easier said than done. I completely appreciate that. However, if you can do this, it makes such a massive difference. So breathe, try to relax, breathe nice and easily, try to stay calm. Use painkillers to try to get on top of the pain situation. Support the joint, again, to try to help with pain management and to take the pressure off of those muscles. Try heat, again, to try to allow those overactive spasming muscles to relax. Use distraction to try to focus your attention away from this situation for the time being, and use some very gentle massage if you can, which sometimes can help relieve those muscles and help the joint slip back into place. So the big idea, as mentioned, is to try to stay calm, to keep on top of the pain and allow the muscles to relax. Why is this the case? Because again, if those muscles are exerting this pulling force, then you are going to have a much harder job of trying to allow that joint to slip back into place again. Now, what if it doesn't go back? What if that joint doesn't find its way back in? Well, don't expect it to go straight back in again. And again, quite understandably, there is a level of expectation when a joint slips out of place, whether it subluxes or dislocates, to get it straight back in again. That it comes out, you panic, you think, oh, my joint's out, I need to get it back in. And then people start to push and shove and move around and everything. And the more you start to push it and shove it, the more it reacts badly often. So again, the more it stirs those muscles up into spasming and exerting that pulling force, making it much harder to get it back into place again. So it's not unusual in people with hypermobility who suffer these incidents for joints to remain out of place for hours or sometimes even for days. And the thing to remember is that once it's out, it's out. It's already out. It's not going to go even further out. It's already out and it's happened. So try not to panic about it, and just remind yourself that if that joint actually went out, it can, hypothetically or realistically, if it went out, it should be able to find its way back in again. So I have a picture here of a child with its head stuck in the railings, and I use this analogy in that if the head went through the railings, then in theory it should be able to come back out again, but it doesn't in these instances, and the fire brigade have to come out and they have to try and crank open the railings and get the head out and everything. Well, why is this? The head didn't suddenly increase to 3 times the size. It's the panic of the situation. So the panic causes stress, and everything gets tense, and then suddenly the head can't come out the railing, and the situation becomes unmanageable. But in theory, if it went through, it should come back again. And this is the same with dislocations as well. If that joint slipped out, then in theory, it should be able to find its way back again. Nobody's suddenly stuck some kind of big block in between there and stopping it from going back in. So if it went out, then if you do the right things, there's no reason why that shouldn't necessarily be able to find its way back again, providing you can give it the right conditions. So when do you go to hospital or get help? If the limb starts to change colour due to a lack of blood supply, then that is not a good situation and you need to get that seen to. So you should go to hospital in those situations. Or if your limb goes completely numb and you have a total lack of sensation altogether, then you need to get that seen to again. If you've tried all of those management strategies that I've mentioned and without the expectation of it to go straight back in, so if you've given it an adequate period of time but you're still really struggling, then that's another reason to then go to the hospital if you're just really struggling and you cannot cope with it. But what happens if you do go to the hospital, and this is the reason why I don't advocate people going to the emergency room if at all possible. Because when people go to the emergency room, what usually happens is, first of all, they'll sit there in the emergency room for another 3 or 4 hours because they won't be deemed as a high priority. And so that's not a nice environment to sit in with a dislocated joint. And then eventually, when they do get to see you, what usually happens is the emergency room doctor will then start to take your joint and often will try to yank it back into place again. So they'll be trying to put it back into position forcibly. And how do you think your body's going to react to that? Not very well. So what usually will happen is they'll forcibly relocate that joint, and that will freak the muscles out even more, and then the muscles will just spasm again and they'll just pop that joint straight back out again. And then you'll get involved in this situation, this battle, where the ER doctor will push it back in again, and then the muscles will pull it out again, and it'll go in and out and in and out. And then I've known sometimes, obviously this can perpetuate even more pain when the anesthetic wears off because of all the trauma of that going on. But I've also known situations where, as a management strategy, the ER doctor will then put that joint in a cast, in a plaster cast, to try and hold it in place. So I've seen many people turn up with dislocated patellas, dislocated kneecaps, and the ER doctor has been shoving and pushing and shoving and pushing, and put it back, and the muscles have pulled it out, and they put it back and pulled it out, and then what happens is they'll cast it, they'll stick it in a cast, which again is a really horrible situation, because what happens then is you have a battle going on underneath that cast where the muscles are in such spasm that they're fighting underneath that plaster cast to try and pull that joint out, and the cast is resisting it, and that becomes incredibly painful and very, very unhelpful. So my advice generally is not to go to the emergency room, and to start to try to get used to the protocol that I've mentioned as the management strategy. So you need to learn to stay calm and self-manage. And I know it's easy for me to sit here and say that, but I can guarantee, well, not guarantee, nobody can ever guarantee, but I can certainly say that I've known many, many, many patients who have had these incidents be able to work through this protocol and start to get control of this. And it's a leap of faith as well. If you can actually work through this protocol, stay calm, breathe, relax, allow the muscles to calm down. If you can actually do it and work through it and make it happen once, then you know it can happen, and you know you can do it, and you know you can control it. And once you know you can do that, then each subsequent time can get easier and easier. And it does, and it can happen quicker and quicker, and you can manage the situation better and better. So what about damage? Because this is something that people often worry about as well, again, understandably. Well, it's unlikely in people with hypermobility that they would damage a dislocated or subluxated joint. Usually this joint laxity, this inherent laxity of the joint, allows for those ligaments and capsules to stretch. So rather than tearing through these structures, which often would be the thing that would happen in a non-hypermobile who sustains a traumatic dislocation, where they would tear through their joint capsule usually, the laxity in somebody with hypermobility would allow for that joint to come out without the same kind of damage happening. So a dislocation or a subluxation of a joint, usually in somebody with hypermobility, is mostly just distressing and unpleasant, as opposed to out and out damaging. So once this has happened, one of the most important things that you can do is actually learn lessons from a dislocation or a subluxation. So if you've had one of these events and you've managed to get through it and you've come out the other side of it and the joint is back in place, you need to reflect on what happened. So were you moving in a way that perhaps caused the joint to dislocate? Did you hold yourself in a particular position, or did you move without thinking? Did you do a kind of a silly movement that caused that to happen? So reflecting on that is important, because obviously you can then try to avoid repeating that mistake. What was your posture like? Were you standing in a very poor posture or in a particularly compromised position that increased the risk factor of this happening? Again, reflecting back on that and thinking that, yes, I realize why this might have happened, will help you try to avoid doing that again. And were you tired, or were you overdoing it? So if you're really tired, you know, if you're very fatigued, and as we know, fatigue is a prevalent feature of hypermobility. If you're very, very tired, then the muscles sometimes won't have the same amount of control, or if you're overdoing activities, then again, that can sometimes lead to these incidents happening. Or were you stressed about something? Because again, we know that stress, higher levels of stress, can cause these incidents to happen. So prevention is better than management. So we've talked through a management protocol that you can use, but in the ideal world, prevention and stopping these incidents from happening is the best thing of all. So this is where physiotherapy or physical therapy comes into play. So we need to go through physical therapy in order to learn to control the muscles and use the right ones. So as I mentioned earlier on in the presentation, people will often find themselves in a situation where they have inappropriate muscle patterning going on. So the wrong muscles working because of their inherent joint flexibility and joint laxity. So some muscles are overworking and they're pulling, they're exerting these pulling forces onto joints that are increasing the risk factors of the joints coming out. So through physical therapy, what we can do is identify those muscles that may be overactive and firing inappropriately, and then we can start to train the right muscles to work, and then we can start to build the stability of the correct muscles around a joint. Because if you can start to build and strengthen the right muscles that support the joint, then that can significantly decrease the frequency of these events happening, and in some cases stop it happening altogether. So physical therapy is absolutely paramount to prevention of dislocations and subluxations. So if you are a recurrent dislocator or a recurrent subluxator, then going through a physiotherapy protocol is absolutely paramount in order to prevent these occurrences. Then also going through rehab to improve proprioception. So not only do we need to get the right muscles working and build the strength and stability of the correct muscles and switch off the inappropriate ones, but we also need to understand about joint position sense and awareness. So again, learning that through physical therapy, so to develop a sense of proprioceptive awareness. And this is something that can be trained. It can be done through a variety of means. Again, this is probably for another presentation, but you can use things like mirrors and tape and different kinds of exercises to try to improve and sharpen up the proprioceptive system. And if you can get a better sense of joint position sense, then you reduce the risk factors of these incidents happening. And then possible use of supports or braces can prevent these things from happening. Now, I am not the world's greatest advocate of always using lots of supports and braces. I think there is most definitely a role for splints, supports, braces, particularly for very unstable joints. However, there is no substitute for actually building up your own internal muscle system, which is the best thing of all. So supports, splints, braces, etc. are a very useful adjunct that can be used. So in situations where somebody's risk factor may be greater for a joint popping out, so if you know you have very unstable knees and you're going to go for a bit of a walk on uneven ground or something like that, and you know that there's a very high risk factor that those knees are going to slip out of place, then by all means put knee braces on when you go for that walk to help prevent that happening. But outside of that, you then need to do the work at building up your own muscle system around those knees in order to get them stronger and more stable and to build the proprioception. That's the most important thing of the lot. So the supports and braces are a useful tool to help with that process. And again, trying to manage stress and anxieties. Stress and anxiety often causes adverse symptoms in so many different ways, but it also feeds into dislocations and subluxations as well. So there's lots of evidence to suggest that you know, if you have higher levels of both of this, then this can lead to these incidents happening as well. So it's obviously not easy to manage your stress and anxiety, but you know, just practicing mindfulness, meditation, psychology, counseling, talking to friends or family, all of the strategies that work for you can try to help reduce these incidents happening. So the key to managing dislocations and subluxations is basically the more you stay calm and manage it yourself, the easier it should get each time. So calmness, zen, chill out, relax, easier said than done, most definitely easier said than done. However, if you can believe in that and trust in that and try to stay calm, let everything calm down, let the muscles relax, then that's the key to being able to get through this situation. And as mentioned, once you've done it once, you know you can do it. And once you know you can do it, you'll find that you can start to do it quicker and more efficiently each subsequent time. Thank you.
Thank you so much, Jason. That was a very informative webinar, and looking at the chat and looking at the questions, we've got a lot of people that are extremely thankful for what you presented today.
Thank you.
We already have a few questions in. We probably have more than we'll be going to be able to get to. So if your question does not get answered, please reach out to our helpline. You can email, you can call, and we'll get your questions answered. For our first question, Is there anything I can do to prevent my shoulders from dislocating and subluxing in bed?
Ah, yes. Yes, so this is a frequent occurrence. So shoulders slipping out in bed. So this is one of those situations where when you're in bed and when you're asleep or when you're very relaxed, the muscles that are usually holding the shoulder in place will relax to the point that that joint will then slip out. So you kind of almost go in the reverse, if you like. So you lose all sense of muscle tension, which up to that point during the day has helped support that joint in place, and then it slips out when you're so relaxed and asleep. Again, there's no absolute super easy answer for that whilst you're in bed. So sometimes it depends on how frequently that happens. So you can use pillows and cushions just to support the joint when you're in bed, just to stop the shoulder from moving and slipping around. Or if it's a very frequent and distressing occurrence, then in some situations, some people will sleep with a little shoulder brace on, and there are particular kinds of shoulder braces that people can pull on just to maintain that whilst they're asleep. But again, that brings us back round to doing the stabilizing and strengthening work outside of that. So the more you can then work on the physical therapy and actually build up the strength and stability of those muscles around the joint, then those occurrences should actually reduce in bed. But that's probably the best way of managing that situation.
Alrighty, thank you so much. We've had a couple questions in on this one. My subluxations seem to be worse during ovulation. Do you have any idea on the cause and how I could properly manage that?
Yeah, so interesting. There's no hard and fast evidence that necessarily links the two, but I can certainly say that anecdotally, I have known a lot of my patients to complain of increased frequency of dislocation and subluxations during those times. I think it's becoming more and more apparent to people in the field of hypermobility that there are most certainly hormonal influences at play with regards to this condition. Unfortunately, at this point in time, there isn't a sort of hard and fast solution to that. So I wish I could say, oh yes, if you always use the contraceptive pill, or if you're on take this, that, or the other, then it will help. But unfortunately, I don't have an easy answer for that. All I can say is that yes, we're aware that this does happen. And there are more obviously vulnerable times of the month for these incidents to occur because of those hormonal changes. And again, bit of a broken record, but the best thing you can do really is try to build up the strength and the stability of the muscles outside of during a period of rehabilitation to prevent that from happening. So yeah, unfortunately, I don't have a better, easier answer than that, I'm afraid.
Alrighty, thank you so much. Our next question is one that was very popular, and it definitely hits home for me as well. Rib subluxations. Some of the most painful things I've ever experienced, and doctors don't seem to believe me. How can I talk to them about it, and how can I prevent that from happening?
Sorry, I missed that last bit. How can
I prevent that from happening?
Just before that bit. So they're one of the most painful things.
Most painful. Doctors don't believe when I tell them.
Yeah.
And then what can be done to prevent it?
Yeah. Okay. Yes, they most certainly do happen. I can certainly confirm that I've seen many people with rib subluxations and rib dislocations. They are amongst the most painful things that can happen, and sometimes they can get a bit stuck. it's probably one of the most difficult of all the subluxations or dislocations to manage. It's because of the nature of ribs, you can't almost work them in the same way that you can with other joints. The principles of managing the situation are the same as the principles that I went through here. So again, just trying to stay calm about the situation, trying to apply heat. A little bit of gentle massage often can be useful for ribs in particular, and analgesia, painkillers. But it can take ribs a fairly long while to find their way back to their original position again. They do get there in the end, providing the conditions are right. But you know, there isn't like an easy sort of, oh yes, hook your finger around here and give a little pull to the left or to the right or something, because again, it's one of those things where sometimes if a rib is out and you're understandably trying to sort of fish around and pull it, then unfortunately that can sometimes self-perpetuate the situation. So again, I would lead people back to just trying to do some relaxed breathing, because then that can sometimes expand the action, the bucket handle movement of the ribs, and allow those ribs to find their way back again. So some nice sort of breathing exercises, if you can manage those with adequate painkillers as well, using heat. But ribs are nasty dislocations to have, yeah, it's something that you have to just kind of give a little bit of time to and try to stay on top of. But there's not like an easy movement. Sometimes some people will find certain side stretches can help open up the intercostal muscles to help that rib find its way back again. But it's tough. It's a very, very tough dislocation or subluxation to cope with. So yeah, sorry.
Alrighty, next question has to do with medication.
Mm.
First part is, are muscle relaxers good after subluxations? And the second part is, what do you usually recommend for pain?
Muscle relaxants can be useful. They can be good. In terms of recommendations, it's different for different people. So different things work for different people. Some people just find just basic paracetamol or acetaminophen is enough. Some people have to go bigger and stronger. Some people have to reach for codeine, tramadol, all of these types of things. But you know, you have to be careful when you're working up that analgesic ladder, because you don't want to end up in a situation where you know you start to develop a dependency culture upon very strong opioids, and you know, there's lots of adverse side effects to those as well. So in terms of what I would actually recommend, there is no one suggested best medication for the pain of a dislocation or subluxation. It's different strokes for different folks. So some people find certain painkillers effective, other people don't like them, and other people like other things. So it's kind of a process that you have to work through with your general practitioner, trying out different options and seeing which helps to take the edge off for you. And I say take the edge off because, again, it's the expectation that a painkiller will completely eliminate the pain of a dislocation is something to be mindful of, because often with painkillers and muscle relaxants, even to that point, we're looking for something that's just going to bring those pain levels down and take the edge off, because these incidences can be extraordinarily painful. And so we can't always expect that we'll take whatever painkiller it is and then that will just completely eliminate the pain. So it's looking for something that's just going to help with that process of breathing, supporting the joint, etc. It's something that's just going to bring those pain levels down to allow everything to just calm down. But it is a process that you really need to work through, trying different alternative options, because different things work for different people. So there isn't one suggested best.
Thank you so much. What is the best way to find a physical therapist that is familiar with EDS?
Well, I mean, I can speak for the UK. In the UK, we have the EDS UK charity, and out there, you know, you guys, I'm sure, at EDS International have helplines. So one good way is trying to call up the helpline and asking if they're aware of anybody in their local area who has a special interest in EDS. The other thing is contacting the specialist centres for EDS within the country, and then asking if they're aware of any specialist physiotherapy practitioners who have an interest in EDS. Regrettably, there aren't as many around the world as we would like there to be. You know, it is a growing area of interest and specialism amongst physical therapists, and we're trying to get more and more physios educated and interested in the condition. You know, speaking personally, I know that I have lots of visits from lots of physical therapists who want to learn more about the condition, and I encourage them to do that and then go off and set up wherever they are in the country. So I think call the charity helplines and see if they know of somebody. Speak to clinicians at rheumatologists at the specialist centres in the country and ask if they know of anybody. Other than that, you could perhaps just try going to your local physiotherapist and ask if they have an interest or if they themselves know of someone in the local area. So that's probably the best advice, because as of yet, there isn't a specific database necessarily.
Alrighty, thank you so much. What is your thought on surgeries to correct repeated dislocations for like shoulders, wrists, knees?
Yeah, great question. I am not a fan, certainly not in EDS. People with EDS generally don't tend to do well with stabilization surgeries, and this is for a couple of reasons. And the first reason is that somebody will undergo a surgery and they will tighten up around the joint. If I take a shoulder as an example, they'll do like a capsular tightening, and they'll make everything really tight in there. And sometimes what happens is they'll tighten everything up so much that that person will actually lose range of movement in that joint to start with. And then what happens is, to begin with, that shoulder feels nice and stable. And you could just as easily apply this to a knee or any other joint. It feels nice and tight and nice and stable to begin with. And that's all lovely and nice. But because of the inherent nature of the healing of this altered collagen, what happens is people with hypermobility, with EDS, don't always tend to heal particularly well. And so they start to get a buildup of scar tissue. And that can start to cause a bit of a problem. And then what also happens is, because of the nature of their collagen, they over time start to develop that laxity again. So that tightened up joint and those tightened up tissues start to become loose and lax again. And then what happens is eventually they'll get loose to a point where they were pretty much like they were before, except the situation becomes a bit worse because you've then got a failed surgery with scar tissue in there as well. And the situation can often be even worse than it was to begin with. So I'm not a big advocate of undergoing surgery, stabilization surgeries for joint dislocations and subluxations. I think it's quite a last resort thing. I think somebody should always try to work through strengthening and stabilizing and proprioception protocol first, and give that a good, adequate amount of time, because this is something also that takes quite a period of time to develop that strength and stability. But it is most certainly achievable if it's approached in the right way. I won't say that you can entirely and completely eliminate dislocations and subluxations in all instances, because that isn't always the case. But I think giving that rehab an adequate amount of time is the very, very best thing that you can do. And then if you've really given it your absolute best shot, and then you're still suffering from recurrent painful dislocations, and you've really given rehab the best shot that you have, then that's the time to potentially consider surgery. But I really wouldn't enter into that until you've given everything else a really good go.
That is fantastic advice. Thank you so much. We've got time for maybe 2 more questions.
Sure.
The first being, what are your favorite ways to improve proprioception?
Oh, there are so many different ways. I could do a whole other webinar all about proprioception. I think I like to use mirrors. So when I'm going through certain exercises with my patients, I get them exercising with mirrors so that they can get that visual feedback about where their joints are, so that they can start to appreciate the positions that they're in, so that when they go home and continue with their exercises, that they're getting that visual feedback. And the more that you reinforce that visual feedback, the more it starts to sort of burn into your brain as to where your joints should be. I use tape sometimes. So I use tape to give people proprioceptive feedback. Putting tape on joints gives their brain an awareness of where that joint should be sitting and what that should feel like, which is also a very useful tool to use. Using compression garments as well, actually. So having people wear compression garments is a really good way of encouraging proprioceptive feedback as well. So it gives you a sense of where your joints ought to be and where they should be. And then there's a whole variety of different kinds of exercises that I use with people. So I'm a big fan of using exercise balls, gym balls, the big Swiss balls, the big gym balls. You can use those in a variety of ways because of the unstable nature of those gym balls. That gives you the capacity to be able to use those in ways of having to stabilize and control that ball, and in doing that, that helps to work the proprioceptive system. So that's a nice way of exercising, using those, and using kind of certain gentle, unstable surfaces and having to control those allows for retraining of proprioception. So there's loads and loads of different kinds of exercises and different methods, and as mentioned, I could take ages going through a whole protocol again, but there's some of the sort of principles behind good proprioceptive retraining. But definitely go for some compression garments. They're really useful.
Thank you so much. And for our last question, and like I said earlier, and like Jason said, if your question doesn't get answered today, please reach out to our helpline. You can call them, you can email them, and they will get back to you and answer your question or direct you to the person that can help you the most. Our last question, though, is what can you do about spasms that are trying to pull a joint in a particular direction to prevent acute pain? What's the best way to break that cycle?
Yeah. So the best way to break that cycle is through muscle patterning retraining. So that's through physical therapy. So it's learning how to switch those muscles off. And sometimes you have to go through a process of taking that rehab right the way back to its foundation level. So for example, if I take a shoulder as an example, sometimes with something like a pec major or lats that are usually very, very, very overactive, sometimes you have to get somebody into a completely fully supported supine position and allow them just to lay there and just start to use their brain to feel those muscles. So to actually put their hands on those muscles and feel how overactive and how tight they are, and then just start to try to consciously see if they can let that go to begin with without doing anything more than that. So just learning to feel it, to feel that overactivity, and then to gain conscious control of that. And this is something that can be done because, you know, ultimately at the end of the day, your brain controls your body. And so you have to learn to find that switch to switch off those muscles, and feeling and touching is a very useful way of doing that. And then once you learn how to switch those muscles off, then it's a case of starting to work the right muscles and going through a rehab regime where you start to exercise the right muscles, but to the exclusion of those overactive muscles. So again, it's using, often I like to use touch feedback, where people will start to work the correct muscles, but then be feeling in the areas where the wrong muscles are to make sure that they don't suddenly fire and switch on. And then if they do, just learning to relax again, reset, and try again. So it's working through that protocol. But there are other sort of fancier methods. There's EMG biofeedback machines where you can put little electrodes onto overactive muscles, and then that shows you the electrical activity of those muscles firing, and then people can often use that for retraining so that they can start to see whether they can switch those muscles off that way. But yeah, it's basically getting conscious control to begin with, and then learning, once you've got conscious control of being able to switch those muscles off just through relaxation. And relaxation is very important. Once you can do that, once you know how to stay calm enough and switch those off, then it's being able to work the right ones to the exclusion of those wrong ones.
Alrighty, thank you so much, Jason. But that's all the time we have for today. We've got 2 comments that stuck out amongst the deluge of thank yous. One of them was asking if you had any plans to create a manual, either a book or a video series, to educate patients and their doctors. And the other one was, there's a lot of excitement about a possible proprioception webinar with you. So we might have to talk. But lots of amazing feedback. So thank you so much for being with us today.
You're more than welcome. My pleasure.
If you would like more information about anything that was presented today, please check out our website for more resources and information. Feel free to give our helpline a call or email, and definitely consider signing up for our newsletter if you haven't already. It's a fantastic source for the most up-to-date information and upcoming events. Our next webinar will be on September 18th. We have Jeannie DeBon joining us to talk about her newest endeavor, the Zebra Club, which is a comprehensive collection of movement classes for people with hypermobility, EDS or HSD, and chronic pain. You can look out for that sign up next. We also might be having a surprise webinar for National Dog Day. We are going to try to get Ellen Lennox-Smith to come and give a presentation on service dogs. Keep your eyes open for information on that as we try to get it together. Thank you so much, Jason. Your presentation was extremely informative and very helpful. Technology permitting, this webinar will be available on our YouTube channel within a few weeks. If you found this webinar helpful in any way, please consider hitting that like button once the webinar is available on our channel, and subscribing as well. That way you can be alerted to when we're uploading our videos. Also, there is a donation button on our main YouTube page. It's thanks to donations that allow us to continue to provide programs like our webinars, along with other great projects and research we're undertaking. Once again, thank you so much, Jason. I know I got a lot out of your webinar, and it looks like our attendees did as well. I hope you and everyone that joined us today has a wonderful rest of your day.